So everybody, welcome back. I hope I've not tired you enough too much. So welcome back to this next lecture, which is part of the same Gyan series. This is basically on microneedle technology based subdermal diagnostics, right? What I want to do here is you'll be seeing a lot of slides which you might have seen in the past. I'm just going to take you back again. We're going to do mostly a recap of all the human studies that have been done using these subdermal devices, and I think it'll be a good recap, especially given the fact that we've just visited the animal studies there. Now, when we were talking about the animal studies, I did tell you about how useful the human studies have been and how we took the experience from the human studies into the animal studies, right? I was trying to, we were trying to look at the analogy there. We were trying to look at the different scenarios, what happens in ambulatory humans and what happens in ambulatory animals, how we can learn the lessons. For example, I mentioned about AI assisted devices, right? That was something that came from our experience of doing human studies. So these are the studies that have actually taken us there. Now, I would also like to mention one thing here, which is about digital twin. Have you all heard about digital twin? Right? So digital twin is a technology which kind of helps you, which is a twin, in the sense that it's analogous. There's some common goals there, and then you can learn from that particular technology. So one such technology is this technology, which we call as this is basically a commercially available device, Freestyle Libra. It's basically a continuous glucose monitoring sensor that monitors glucose, but this is not inserted, this is something that's implanted, right? So what I'm going to do is I'm going to open up this box and show you how this is used, and then I'm going to show you how this is a digital twin to the subdermal wearable technology and how we use this technology to develop our subdermal wearable patches, right? Okay, this is more used mainly for glucose, so we can learn from the experience of this particular technology, from the roadmap of this technology, the success and failures of this technology as to how we can how we can develop things further as well for the subdermal patches as well. Okay, I'm going to open this. Has anybody seen this before? How many of you have seen this before? Libra 3, I'm talking about Libra 3, not Libra 2. Okay, so nobody's seen Libra 3. Okay, so these normally come with an app on your phone. You need to download the Freestyle Libra 3 app that you normally have, and then you have this particular device here. And this morning we had this lecture where we were talking about NFC and those kind of things. Freestyle Libra 2 works on NFC. This one is more, I think, Bluetooth based. So information that's generated by this sensor goes onto your phone directly, right? There was also this mention about using this as, having to run it past your, using NFC and doing a quick scan. That was there for a reason, right? And that's why I say this is a good digital twin. The reason they started doing this was, you talk about implantable sensors, they are implanted quite deep into the body. When you implant something deep into the body, the problem you have is you will have biofouling effects, because don't forget, these sensors are meant to be used over a period of 14 days. Right? You implant something in your body subcutaneously for 14 days, there's definitely going to be some biofouling there. And what does biofouling do? It goes and contaminates, or it goes and basically forms a capsule of protein around your sensor surface, right? And that actually starts to affect your sensor performance. So what happens is you start getting problems with accuracy and precision of your sensors, and that in real life would lead to false alarms. There have been times when people, the sensors are reading low glucose values. Why? Because you have a capsule formation, there's a less amount of glucose actually diffusing to the sensor surface. And when you start reading low glucose values, that's an indication of a person going towards hypoglycemia. You start to get alarms, false alarms, right? And people look at it and say, I'm feeling fine, but my sensor reading is dropped down. Right? So this used to happen when people used to monitor things continuously, always looking on what the readings are. So what people have started doing now, that's why the technology was modified, and they've started introducing something called as flash devices, wherein you take your reader and you flash it against your device, and you get the readings just when you feel that something is wrong with you. So you kind of use your own instinct, and you use what your instinctive feeling is, and you then look at the readings and say, oh, now I can confirm that there's something going on there. So that was flash technology. This technology is also similar, but here, as Professor Khalid mentioned, you're using a Bluetooth, so all the data goes through your Bluetooth. You need to keep your Bluetooth on in your phone and in your app, and it directly goes in there, and whenever you want to watch your readings, you can watch it there and then. Okay, so let's open this up. That's how it looks like, right? Yeah, that's how a Freestyle Libra 3 sensor looks like. Simple thing, you open it up, right? Ideally, I would advise you not to look into it, because if you look into it, what do you see? Can you see it on the screen? No, you can't see it on the screen. You can see there's a hollow needle in there. You would think, oh, this hollow needle, oh, this is, I'm going to get a hollow, you know. You don't want to, so you take this, you just open it up. This is where the hollow needle sets in there. You take this one, and then you can go at the back of your arm, ideally somewhere. It depends whether you want it visible or not. Some people, especially who are into sports, they like things to be visible. So you go in here. You can use your right arm. You fold your arm, and just. Did you hear the click? That's because it's a spring-loaded applicator. I did feel a bit of, a slight bit of a pain, a tingling sensation there as well, as you would call it. And then you can just take it off. The sensor has already been implanted. Right? Good. Ease of use, right? That's why I call it a digital twin. So now we need our subdermal wearable devices to have the same kind of easy format. You see, I did a demo and I showed you how you can use these sensors now. Okay, and then this can be disposed of, and the next thing you do is you bring your phone, and it says apply a sensor. It gives you all the directions, all the instructions that you need through the app. You say next, and then you scan your sensor. Should be scanning the sensor, and then it will start working in 1 hour. There's a warm-up time of 1 hour. There we go. And back, next, scan the sensor. I'll just make sure that my Bluetooth is working so that it can pick up the sensors. Yes, the Bluetooth is on. Sorry? Scan new sensor. It should be fine. I think this. There might be some issues there, but that's more an issue with the Bluetooth there. But the reason I showed you this sensor, and the reason I showed you the whole implant, it'll come up. It'll come up soon. I think because we have to stick to the time of this presentation, so I'll move on to the presentation here. All right. So did you get the idea of digital twin? Did you get an idea as to how we use a digital twin to kind of develop our product of interest? You take an example and you say, oh, this is where I can where I can learn some important lessons, and which I can then adopt and implement for my own piece of technology, my own medical device that I'm planning to use. Okay, so this one you'll see a lot of repetition, a lot of slides that might be repeated, but that's again just to consolidate on the facts and to ensure that you've understood this whole idea of subdermal wearable sensors. Now, the nice thing about this sensor is the ease of use, right? I just mentioned. I'm going to run through this whole thing. So the learning objectives of this particular talk is basically to understand the role of microneedles in interstitial fluid access, how you can access the interstitial fluid. Let's review the biosensing device that's used with and using the electrochemical methods, and we'll also be exploring integration into wearable platforms, and then compare this subdermal with sweat-based sensing as well. Just basically a comparison between subdermal. This is going to be the last lecture, which I believe on the wearable side of things. After this, we'll be discussing other things which will be more challenges and stuff like that. But basics, fundamentals, and all those things that you need to venture into this field, this is going to be the last lecture for that. So please pay attention and make sure you make the most of this. So first of all, question that we ask is, why do we need subdermal diagnostics? Right? So what's the difference between epidermal and subdermal diagnostics? Well, if you look at this microanatomy of the skin, in case of epidermal sensors or epidermal wearable sensors, you have sweat that's on the surface of the skin, and then you try to that's something that can easily be accessed, not a problem at all. But as long as you're sweating, you've got some sample there, so you access that and you can measure that, and you can measure that for things. It's easily accessible. That's a nice thing here. Now, to access anything underneath the skin, you need to have something which is a bit more sharper, right? Something that's minimally invasive. To access the skin interstitial fluid, I showed you examples. You can use suction blisters, you can use microdialysis. That's more for clinical side of things. If you really need some biomarker which is in the interstitial fluid, but that actually has got a clinical outcome there. But for things like healthcare, where you're trying to monitor your metabolites of interest, you need something which is more minimally invasive. This was actually the main purpose of your continuous glucose monitoring sensors was more for clinical purposes, mainly to monitor your glucose in a continuous manner, so that that would help you administer insulin accordingly and manage a clinical condition which was diabetes. That's where it all started. Now they are expanding on the market. Now they're saying they want people to try these sensors, have different kinds of food, to understand your own physiology, what's going on in your own body, to have different kinds of alcohols, people who are big fans of alcohols, to see which alcohol gives you a spike, which alcohol doesn't give you a spike, which food gives you a spike, which food doesn't give you a spike. I mean, we have these YouTube videos from people using similar devices called as Zoe devices, wherein people have these devices and they have different types of foods. They have food, for example, just a normal naan with dal, and some people try naan, dal and some salads with it, and they show that when you have salads, your peaks are comparatively lower. You don't spike that much. So this is basically trying to work out your own lifestyle. This is basically wherein you're trying to see what is good for you. Basically personalizing your own diagnostic devices, or personalizing your own well-being by using these kind of devices there. So skin interstitial fluid, coming back to that, reflects what we call as the blood metabolite, because you have this subvascular plexus there, and the subvascular plexus is in continuous equilibration with the skin interstitial fluid. Skin, as I mentioned, is the largest organ in the body. Skin interstitial fluid, you have about 12.5 liters of skin interstitial fluid, and it is a treasure trove of biomarkers. And we've also seen this new hypothesis, this new reports which suggest that if you have two organs which have got the same embryonic origin, if they are from the same ectoderm, mesoderm or endoderm, then they would have the same form of biomarkers there. So skin is a good way, because skin originates from the ectoderm. Any other organ that originates from the ectoderm will have, you would be able to see the biomarkers similar to that particular organ there as well. Skin has got a lot of nerve endings. So if you're looking at neurodegeneration, you can actually look at skin. You can all have biomarkers of neurodegeneration as well. The skin interstitial fluid can be accessed in a minimally invasive manner, as can be seen from this particular image. I'm showing you this image again, but I think this is the best representation to show you the difference between a hypodermic needle and a microneedle. And also we'll explain you the fact that why we do not want to use the term microneedles, because if you say microneedles, people would think that this is needles, and then they imagine this kind of a needle here, right? But when you say subdermal wearable device, which have projections or micro spikes you were using, which was a term that we introduced initially, then it's much more acceptable. As I said, the devices are useless if they're not accepted by people. If you scare people right at the start by using the term microneedles, it then puts them off, all right? And then the devices don't get very high acceptability. And that's the problem that you've had with these. These have become very popular now, but earlier the acceptability was very, very poor. The acceptability was less than 20%. So less than 20% people with type 1 diabetes would actually carry on using these devices. Although the clinical evidence was that the more you use continuous glucose monitoring sensors, the more control you have on your glycated hemoglobin. Does everybody understand glycated hemoglobin here? So for those of you who don't know what glycated hemoglobin is, the blood which carries the sugar, right? The main component of the blood is hemoglobin, right? The main function of hemoglobin is to carry oxygen. So it binds with oxygen and it circulates oxygen all over through the entire body. However, when you start having sugar, and when your sugar levels start going much higher, then what happens is the high levels of sugar start binding to the hemoglobin as well. And when they start binding to the hemoglobin, then they form a compound which is called as glycated hemoglobin. So glycated hemoglobin is a good indicator of your disease. A lot of people who are are suffering from type 1 or type 2 diabetes, the way because glycated hemoglobin tells you about your behavior over the last three days. You can have a glucose test next morning, you can do fasting, you can fast for 3 days and go and say, oh, my sugar levels are quite low there. That doesn't give you a good indication of what actually your glucose levels are. A good indication of your glucose levels is glycated hemoglobin, and that's what's normally measured either 3 months or 6 months. After a certain age, it's measured every 6 months, or sometimes even annually, right? Because that's telling you how good you've been, not over 2 days. You can do 2 days of fasting and eat a lot over the rest of the days. It gives you an average over 3 to 6 months, and that's a much better measure of the level of glucose level in your body. All right. So coming back to the ISF, you can tap into the ISF with minimally invasive microneedle devices, and you can access the biomarkers, and you can monitor things in real time. And the nice thing with ISF is also the fact that there's less variability with sweat, and because it's in direct contact with capillaries, you have direct access to capillaries as well here. As I mentioned, you have these subvascular plexus which will give you direct access there. Okay, I've already shown you these images before. Microneedles, for those of you who are attending this for the first time, microneedles can come in different shapes and sizes. You can have solid microneedles, hollow microneedles, and they can be fabricated using different techniques. This is not new. These have been there since 1970s. I think I might have a slide next. Yes. So they've been around since the 1970s. The original application of these microneedle devices was for transdermal therapeutic drug delivery, right? So they were mainly used because, as I said, the skin has got the stratum corneum layer, and the stratum corneum layer basically acts as a fantastic barrier, and it prevents the diffusion of that's what gives it the skin the property of being waterproof, right? And it also acts as a barrier for any foreign substances to go through the skin, right? So if you want to administer drugs through the skin, you have to break the stratum corneum. Otherwise, there are only 20 drugs that can be applied transdermally. The balms and all those things, those are all transdermal, but they don't go that far. They are more kind of placebo effects, because you normally smell the balm and you feel irritation in the eyes and nose, and you think you have already been cured. That's the placebo effect there. Not all of that actually goes into your systemic circulation. Okay, so microneedles have been there since 1970s. As I mentioned, they come in different shapes and sizes, and the real applications were mainly drug, which is transdermal drug application or transdermal therapeutic drug administration, and most importantly, recently they have been used for intradermal vaccine delivery. And this was very, very important, especially when we had the pandemic, when the whole world was looking for a vaccine, right? Vaccines were available, thanks to the way we all worked very hard and got the vaccines right and this thing, but distribution of vaccine was a big problem because of the cold chain requirements, right? If you can administer drugs or administer vaccines intradermally using microneedle arrays, you can actually then address the problem of cold chain, because the vaccines are normally in the form of powder, straight away loaded onto polymer films, and they go and dissolve themselves in the skin interstitial fluid. Because they're in solid state, you don't need any cold chain there, right? So that's why these microneedles are also very popular for therapeutic drug delivery applications as well. And you can actually combine them. You saw the talk on artificial pancreas, wherein you were talking about insulin pumps for delivery and microneedle array and your sensors for diagnostics. You can combine therapeutic drug delivery and diagnostics and make it into a theranostic device, wherein the thera comes from the therapeutic drug delivery and the gnostics comes from the diagnostics. Very, very useful tool for vaccine. You've administered a vaccine somewhere in Kampala or somewhere in Accra. You do not know whether the vaccine is efficacious or not. But if you have a diagnostic, if some of them have been modified into a sensor which can measure immunoglobulins, you know whether the vaccination has been efficacious or not. Similarly, cancer immunotherapy. You can basically administer the immunotherapy and then measure the response to the therapy by using the diagnostic tools. So these are some good theranostic applications. Coming back to the sensor side of things, coming back to the subdermal sensors, we normally have a standard setup. Your standard setup would be what you normally see in an electrochemical setup. You always have a 3-electrode system or a 2-electrode system. You can have a working electrode, a counter electrode, and a reference electrode. Right? You apply the potential between your working electrode and your counter electrode, and you have your reference electrode to keep the potential fixed, and you measure the current there. All right? Electropolymerized phenols, and you can also have very thin layers. Now again, you saw me implanting this device, right? And you saw there was a needle there, right? Has the needle gone into me? No, the needle is pulled out. Why do we need that needle? Puncture it. What else? Why do you need a hollow needle if you were just going to puncture it? To insert the sensor. The sensor is in the form of, you had that CGM device, right? Have you got it right today? No. No, you don't have it. But yesterday, yeah, we can show you those. We can show you those. Basically, they have a filament, and those filaments are, using the applicator. They're pushed in through a hollow needle, right? And the reason they use a hollow needle there is, number one, the needle allows you to puncture and go down subcutaneously deep into the skin, right? And the second thing it does is, your needle is actually coated with a membrane. It protects the sensing surface as well, right? Why? Imagine anything that you push into the skin. If the layers, because just imagine you have a blank device, you metallize it with a very thin layer, 50 nanometers, 100 nanometers of your metal. On top of it, you have a thick layer, right? What happens if you push the thick layer through the skin? It will be completely delaminated, right? So you need very thin conformal layers. You need to have the functionality of your bioreceptor maintained. And how can you maintain that? By having films that are conformal. For example, electropolymerized polyphenols, electropolymerized polypyrrole films. These are, the reason we use these are because these do not grow beyond 50 nanometers. I have done studies wherein I used epoxy polyurethane membrane, thinking that it will help me in reducing any interference. And I found that when I would push it into the skin, right, and take it back and do an SCM under the lab, the membrane would be completely torn. Right? So we need electropolymerized polyphenols, electropolymerized polypyrrole films, because the electropolymerization ensures that the thickness is 50 nanometers and it's conformal as well. And then we need to functionalize the enzymes. We need it also entraps the enzymes there and keeps the enzyme fixed there. Otherwise, you need self-assembled monolayers to hold on to the enzymes. The enzymes are not very biocompatible if they leach into the skin compartment and through the skin compartment into the systemic circulation. If you look at the label of the enzymes, it says be careful, it may cause skin irritation. If it can cause irritation on top of the skin, you can imagine what it could do under the skin as well. So you've got to be very careful. So make sure that you have entrapped films there as well. This here is a cartoon showing you how a microneedle array looks like. You can see here you have a reference electrode which looks like a bit pinkish in color because it's a silver electrode which has been modified into a silver chloride reference electrode. Very easy to do that. You have this engineered lactate oxidase enzyme, because the problem with the commercially available lactate oxidase enzymes is you are not getting the dynamic range of 0 to 10 millimole concentration. And then you can see here you have a counter electrode which is made up of platinum, and then you have your working electrodes. These working electrodes are actually made up of platinum, and as you can see from those films on top of it, you also have those dots there, and those yellow dots are actually glucose oxidase which are entrapped in the film. Just to show you, everything is very conformal and nothing is sticking out and nothing can be delaminated when you push it into the skin, because the process of insertion into the skin is a mechanically, you're applying forces there, you're applying 10 newtons there. If there's going to be any deformity there, you can easily delaminate the layer, you can easily rip off the layer, and if the microneedles are not functionalized, how are you going to measure things? All right, I think I might have already shown you this picture. This is a picture from the first case study that we did, just to kind of do a quick recap. Again, look at the instrumentation here, right? See here, this is the potentiostat, a huge CHI potentiostat that we have, a device which has been inserted there. You can see we are still using crocodile clips there with wires coming out of the device. This was very, very crude, but for a first try, I think this back in 2013, this is something back 12 years back. I don't think this was a bad try. And then again, you need a gold standard there as well. Your gold standard is going to be one of the things that is normally used in the lab, in a clinical lab. That's your IV cannula here. The IV cannula is to draw venous blood. So you're drawing venous blood every half an hour, every 1 hour. You can't do that regularly, otherwise you can drain the person of the blood. So you're drawing blood every 30 minutes, every 1 hour, and then you're putting it into a machine, a YSI machine, which is used for measuring glucose in the venous blood. Right? And that machine is actually a gold standard. That machine is very well equipped to give you accurate and precise results. So as I said, your measurement, what are you measuring? You are measuring current. And what are you comparing that against? glucose values. So you need to have a look at the plot, and you need those points there. If you remember from the animal studies, I showed you an enlarged view wherein you had the bolus and you saw a postprandial peak. You saw the capillary blood readings in between there, and by looking at the capillary blood readings going up and down and the trends that you see in your plots, you can see if you are able to capture the events. So what you try to do with your sensor initially is to capture the events related to boluses, the postprandial peaks, events related to exercise, the lactate peaks, where the lactate goes up, glucose goes down. So you try to capture the events there, and then you do later on bring in the AI and machine learning to make all of that make more sense. Again, as I said to you before, tolerability studies, which is a big challenge in animals. In humans, it's not a big challenge, because you can have people there who can give you a visual assessment score. They can easily tell you, you're doing measurements in people who are over the age of 18, who can tell you clearly whether the device that has been inserted, what's the pain score for that compared to an IV cannula that has been inserted, right? So here you have a comparison of three things: the microneedle arrays, the cannula, and in this particular case you also have a CGM device there as well. And as you can see, the pain scores are normally lower for the microneedle arrays, which means that they are very well tolerated, right? If I would have been sitting here screaming that the device is painful, I think that is not a good sign here. The fact that I'm sitting here quietly and doing what I'm meant to be doing and forgetting that I have a device implanted means that basically I'm tolerating the device very well, right? Okay, and then looking at the instrumentation side of things, it's very important. I showed you in that image in the animal studies. If you had an instrument on a trolley, could you actually do animal studies? Can you have a trolley running around with a cow in the farm? No, you can't. And look at this here. So in phase 2, you have this young person holding a bag with the potentiostats in it. Can you give a cow a bag and ask it to carry it around? You can't, right? So you need something which is much more discreet, something which looks more like this PCB based device, which can hide under the collar, or you can tag it to the collar or something like that, which is light as well. You just imagine putting a 5 kilo potentiostat on the top of on the neck, around the neck of a cow. It will stop moving around, and then you can't say, oh, it's not tolerating it very well, because you've given it too much weight there. So you need devices which are not just low cost, but which are also convenient, right? I mean, this is an amazing example how convenient it is to implant these devices, right? When you talk about implantation, and these are invasive, I can feel that they have actually gone under my subcutaneous tissue there, and if I take it out, if it's hit one of my capillaries, I can even show you blood coming out there as well. But it's doing the job. It's sitting in there. There's no bleeding right now. There's no blood coming out, right? It's sitting in there and doing its job quietly, right? Convenience. I mean, cost-wise, it's very expensive, right? But again, because these devices are not perfect, that's why we are developing subdermal devices, right? Because these devices give a lot of biofouling. In 14 days, you would expect the biofouling effects to actually, when you pull out the sensor out, it comes the wire filament, which is normally bright in color, like bright white in color. When it comes out, it's gone all dark. And those of you who use the CGM sensor would know that when you pull it out, you can even see traces of blood there. You know that it's badly contaminated over 14 days. So what do? You bring in these subdermal devices. Why? Because these subdermal devices are not implanted subcutaneously. These are sitting on the surface. Skin interstitial fluid above the subvascular plexus, above the nerves, has got less amount of contaminants, has got less amount of things like your albumin proteins and things like that, right? What causes biofouling? It's the albumin, which is a bit lower down, higher levels of albumin. I'm not saying that there is no albumin at all. There is albumin, but it's reduced, and that reduced amount of albumin gives you reduced amount of biofouling. Okay, so this is an image just to show you about the instrumentation and that side of things as well, how the instrumentation evolved in the 3 years during the clinical studies we were doing. And then this is again to show you some data here. I think we've already had some talk on this about how you can smooth the data and how you can bring the AI side of things as well. But these are the early days. These are our results from phase 3 with participants with type 1 diabetes, where we did 24 hours monitoring, and this is how a continuous profile would look like. And then when you plot all of them without the AI, you can see that your Clark grid error looks very much scattered. If you compare that to the one that was shown this morning by Khalid, wherein you have that line in the middle here, ideally you would like everything to go stay along this particular line here. And look at the way the Clark error grid is designed. You are meant, there is some margin of error more in the high concentration region. So this is your concentration, right? This is your concentration from 0 to about 400 milligrams per deciliter. This is the concentration, the range you have. It kind of goes from very broad towards, so you can see here, very, very broad, and it starts to kind of funnel in. It's like a funnel shape. And as you go towards a low concentration, which means that the margin of error is much higher in the high concentrations, but in lower concentrations you have to be very careful. And that's again bringing us to the same problem of hypoglycemia versus hyperglycemia. Hypoglycemia can put somebody into a coma. Hyperglycemia, I'm not saying it's not bad, you need to control your glucose levels, but that happens over a certain period of time. But when that hits you, that also hits you very bad. You might have heard about amputation of some people have infections is not being treated, you have to amputate the leg, right? These are severe cases of how type 1 or type 2 diabetes can go wrong. You might have heard about retinopathies, cardiomyopathy, nephropathy, all those pathies, they set in after a certain duration of hypoglycemia over a longer period of time, because all the hemoglobin is very busy binding to the sugar rather than binding to the oxygen, and instead of supplying oxygen to the cells, especially in the extremities, it's supplying them sugar. Sugar to cells is poison. Therefore, you might have heard about diabetic people, when some of them, when they remove their shoes, the toes fall off because it all decays. It's like similar to frostbite. These are the kind of problems that you have, right? That's why this glucose diagnostics market is a big market, because you've got it's like an epidemic right now. The diabetes all over the world, especially type 2 diabetes, which we are ourselves responsible. I've been sitting on this chair for the last 4 hours just lecturing. I don't get to move at all. So we are all having a very sedentary lifestyle. You're all sitting and watching. I mean, I wish we could all move around, but okay, we can't do that. But of course, when you have the opportunity, then you should try to do some exercise as well. Okay, this is some of the results that we got from our Ministry of Defense project, where we were doing simultaneous glucose and lactate monitoring. Again, to show you how we had functionalized our glucose sensors for monitoring glucose and lactate sensors for monitoring lactate here. Again, showing you the microanatomy of skin, and if you look at the subcutaneous tissue, if you have your the implanted sensors, they would go, if that wire goes down all the way down, deep down into your subcutaneous tissue. So it's quite deep below the dermis into the subcutaneous tissue, nearly close to the muscle. There are some results here to show you day 1, day 2 and day 3. I think I've shown you these results before as well, to show you what's happening after day 1. You can see the current values start to go down. Why is that happening? Because the sensor is degrading. Why is the sensor degrading? Yes, the enzyme is degrading, absolutely right. What is the other thing that's contributing towards the drop in the current values? So you have the sensor, you have the needle, which is functionalized, biofouling. So you have a thick layer of protein being formed around this, which means that your glucose molecules now cannot diffuse easily, because they have to go through this layer. So the amount of glucose molecules that can diffuse to the sensing layer, then that number goes down. Okay, so this is day 1, day 2 and day 3. This is some example of some lactate measurements that were done. As you can see, they've got a super fit athlete on the treadmill doing the exercise, and then you're measuring your lactate measurements in response to the exercise. Well, I'm not super fit, it's myself on the treadmill there. All right, and then this is the biaxial plot that I normally refer to. This is referring to the glucose. You have your current on one side and your glucose concentration on the other side. The blue plot is where you're measuring the current, and the green dots are where you have measuring your capillary blood glucose, and you have a lilac plot as well. That's your secondary reference. You can see that the trends are similar. So you can see that your capillary blood glucose value is going up, your blue plot is going up, and your lilac plot is also going up there as well. So all looks very good, and you're getting data which is, so as I said, what is important for us is these form of events, the postprandial events, where you can capture the events, because we are measuring current, and then you have to correlate the current to the glucose values. And for that, there is an existing technology which is called as factory calibration. Right? That factory calibration actually goes through all the enzymatic degradation process. It looks into the lot number. So all of these devices have got a lot number they've got the day when they were all manufactured, expiry date and things like that. So you can get from that the batch of the enzyme that was used and things like that. You can use that, and then on top of that you use a lot of machine learning and build an AI model around it. And I think there are about 32 different factors that are used to build the whole the software that's used by Dexcom and companies like Abbott. Right? It also takes into account the biofouling effects as well. Again, because it's all predictive, the values you get are predicted values. They are still not accurate values. Okay, and then this also led us to this, bringing us back to the same point that I showed you during the animal studies, bringing in the AI model, right? And I think this has already been spoken a lot about in the last lecture that we had on AI and machine learning. Bringing in the AI makes your life much more easier. So for those of you who are planning to venture into wearable sensors, who would like to use even if it's physical sensors, please bring in machine learning and AI models to make more sense of your data, and do some correlation studies there as well, so that you can actually make more sense, and you can everything looks much more better there. All right, okay. And then these are the results that I already showed in the morning. These are day 1, day 2 and day 3 studies. The problem we have here, which I like in the animal studies and I don't like here, is these gaps that we have. Right? This is because this is how the research ethics approvals, the Ministry of Defense ethics approvals were given. They did not want us to do any studies overnight, and that's why we had to basically stop measurement or stop recording during the night time. But anyway, the results look good with the AI thing. As you can see from the Clark grid errors, most of the green points and the lilac points are in zones A and B. We've all understood that. Everybody here understands Clark grid errors? So what are the 2 important zones in Clark grid errors? That's it. If you understood that, that's perfectly fine. And anything outside that either is an outlier or you need to optimize your device. And then what is this? What is BA? British Airways? Bland Altman plots, right? So this is a Bland Altman plot, which is basically a plot of the capillary patch data versus the mean lactate concentration, and this line is the important line here. If your points are concentrated along that, then you know that you're, and then these are the red lines there, which is your 95% confidence level. As long as everything is there, anything outside that are your outliers, or that means that your sensor needs to be further stabilized. All right, I can see a lot of yawning going on. Apologies, it's not my choice to have it back to back, but please bear with me. We'll be done in the next few minutes. All right. Okay. So these are the human results. So what are the ways in which we can mitigate the biofouling effects? Well, number 1, we are using polyphenols, and polyphenol to some extent is useful in protein adsorption. Right. Subcutaneously implanted sensors have got wonderful membranes. And because they have that membranes, and because you're trying to push a wire, can you push a wire into the skin without any mechanical support? And especially if the wire is coated with an enzyme and coated with a membrane, right? So the membrane is there to minimize the biofouling effects. When you have membranes, the membrane has got pores, and those pores, I think we already heard this from Khalid yesterday, have got pores through which small molecules like glucose and lactate can diffuse through. But albumin, which is a larger protein molecule, which has got about 100 kDa, which is larger protein molecules, none of those can actually go through those particular pores. So it's very important to have this thing, and that's how you can prevent the biofouling effects. Having said all of that, you still will have some biofouling effects. You cannot completely eradicate any biofouling effects, because the body will keep on sending different forms of different forms of proteins around it. Okay. The biofouling, you can also improve this, polyphenol also increases the, one of the reasons we use polyphenol here is it also improves the signal stability over prolonged wear, and it's a hydrophilic surface which is also resistant to interstitial fluid clogging as well. That's how polyphenol layers help in mitigation of biofouling. And then when you look at the human trial results, we got a good correlation. I mean, I've already run through this. Lactate tracking in ambulatory subjects also looked to be very fine. Everything is within the the Bland Altman is within the zone that we are looking for. Okay. Instrumentation, I think we've had a lot of lectures on instrumentation as well, so we won't be covering any more instrumentation. We'll be having a workshop, and where we will look at how how we're going to be making glucose biosensors, but we won't be covering it anymore. What you need here, I think I showed you that instrumentation slide, if you remember, wherein basically, as I said, it's much more convenient if you have devices on a PCB So you can have a PCB which can have you can have a potentiostat on a PCB, you can build a potentiostat on a PCB, you learned that yesterday. You can have a microcontroller there with all the algorithms, with the AI model, which can then help you in filtering the data and giving you clean output values or clean or good predicted values as well, taking into account all the things that undergo, including biofouling as well. Okay, so in terms of instrumentation, it's very important to have low cost PCB platforms, right? If you had if you had a potentiostat that costed 5,000 pounds in building, do you think you can sell it to a farmer? He wouldn't want to buy it, right? He would say, I would want something which is much more low cost. So you need low cost PCB platforms with integrated ADCs and BLEs, and you need they need to be powered by rechargeable coin cells, or if possible integrated biofuel cells. We saw that paper from Joe Wang's group, Weigau's group, wherein they were using integrated biofuel cells which were based on the lactate that's present in the body. And you need it to be in the form of a compact form. Ideally, look at this, that's why I keep on giving this example. The instrumentation here is on the back of it in the form of a disc. That's the beauty of this device. I mean, these devices, if they've evolved over different generations, you've had generation 1, generation 2, generation 3. This is Freestyle Libra 3. Look how they've miniaturized it, and everything is in this particular disc here. We will show you tomorrow one of those devices that have been removed, and we will show you the tiny little components they have on the PCB that's in here. And this has also got the facility to store. So if I lose, so all the data that's in here is stored in, they've stored it in this device, and when it gets the next Bluetooth connection, it then connects to the Bluetooth as well. Up to 8 hours, right? So that's the beauty, and that's why the reason I did this now, I could have done this tomorrow at the workshop, but I did it now is so that I can put things in the right context, and I can explain you this whole concept of digital twin. What should be our motivation? What is our way forward? Where do we learn the way forward? If we are doing things for the first time, what is the example we can learn from? And I think for us, the CGM sensors are our digital twin. If you had, and these guys can learn from us. How can they learn from us? They can start using the same sensors, and they can start doing multi-analyte sensing. They can't do multi-analyte sensing with this format. You may need a wire which will have different parts functionalized with different materials, but that's going to be hard. So you may need 2 filaments, or you may need 3 filaments. How can they do multi-analyte sensing? That's going to be an interesting problem for them to solve. So with the digital twin, you can learn from each other. All right, so that's your instrumentation side of things. And then I think we've already covered this design, and we've looked at the clinical applications. I've given you examples where we've used the subdermal wearable devices, not only in healthy volunteers, but also in participants with type 1 diabetes. Critical care and sepsis risks are very important. Lactate monitoring during sepsis is very, very important. And you can also use the lactate sensors for performance monitoring in athletes as well. And this brings me to the last slide, wherein we're going to have a little bit of an interaction here, a little bit of a quizzing that will go on. First thing that I'm going to ask you is, what do you think are the advantages of interstitial fluid over sweat? Or I can turn it around if you want. What are the advantages of sweat over interstitial fluid? I think we did that yesterday. Yes, so let's turn it around and let's ask the question, what are the advantages of interstitial fluid over sweat? Yes, please. There's one hand up. Yeah, go for it. You can take turns. That's fine. The ladies first is always good policy.
People would not like to sweat every time.
Good. Nice.
As if volume is high, not everybody sweats a lot, particularly if somebody has high body hairs.
Well done.
Taking sampling is difficult.
Yes. I mean, not difficult, it's minimally invasive, but it's not non-invasive. It's relatively difficult. Mike may.
So the ISF has got many more chemicals inside it, but the sweats, that doesn't have the things.
Well done. Any more? Go on. Share the mic, please.
It's similar to the blood chemistry, like the values.
Yes. So both of you have given the answers. You said many more chemicals, and you said it's similar to blood chemistry. What is the important message there? More biomarkers, and yes, please.
It correlates with the capillary blood.
Well done. There's a very good correlation with capillary blood and venous blood there. Any more?
And sir, I already said it because the sweat in the winter season we don't sweat sufficient. And
Yeah,
but
agree, totally agree. So sweating is a problem during winter time. So it's sampling is easier, but what if you're not sampling at all? What if you're not sweating at all? How do you sample then? Unless you have a pioneer sitting in the audience who comes up with a new sampling technique.
Yeah, contamination may be also issue where the bacteria produces some lactate and then measurement may give.
That's why I use the term pioneer. That's a very good. It's a contamination on the skin, causing bringing in the exogenous products. That's another thing. Any more? I'm really encouraged by seeing this response.
Depends upon the external atmosphere, that atmospheric heat and all. So concentration of analyte in the sweat may changes.
Well done. The dynamics keeps on changing in sweat, right? While in the ISF it stays
What's the ISF? It's close relative to the blood.
blood and it stays constant. Yeah, by and large. It actually, so skin, one of the terms people use for skin is a window to the body. By looking into what's happening in the skin, you know what's happening in your body, right? That's why skin is called as a window to the body. Yes, please. Any other? All right, I think that's very well answered. I mean, I'm very happy, Khalid, that this workshop has been for you. It's definitely a big success. Everybody has given me everything that I expected in terms of the answers. So very well done. I think you've covered all the points here.
Credit to them actually.
Yeah, credit to them staying awake and listening to the whole lecture. What role does polyphenol play? There's a gentleman on the.
sir, polyphenol can act as a redox layer.
Well done. Yes, a redox layer. Do you need a redox layer?
And it is also mechanically stable.
Is polyphenol a redox layer?
Sir, polypyrrole is I don't know polyphenol, but I guessing it.
Polypyrrole is okay.
Is a good
But do you need a
mechanical
redox layer?
For movement of ion more efficiently.
So you're talking about the thickness. So it's
Yes.
much more thin film. Okay, fine. Movement of ions, I will take that one. This one I'm doubtful. Movement of ions, I will take that one.
So it can prevent the biofouling
Yes, prevent biofouling.
because it resists the albumin development or not.
Yeah,
So
similar to a epoxy polyurethane membrane. There are mic mein bolo, mic mein.
So it reduces background current.
Reduces background. Why does it reduce background current?
It forms a small, thin layer of
Exactly.
polymer.
So it forms a thin layer, and polyphenol by itself is insulating. What else? There's
So is it due to the selective permeability of the polyphenolic membrane?
That's been answered here.
Yeah.
Good. Same permeability. That's same thing here.
Sir, it block protein adsorption.
That's been mentioned here. Prevents biofouling. Well done.
It can be selective for analytes.
Selective for analytes.
Yeah, like a selective membrane.
That's been mentioned again here. Movement of ions. Permeability. There's one answer I'm looking for. Think on the lines of mechanical. That's where I did this demonstration here. What stability? Stability of?
So when we insert inside the body, it
Yes.
is stable.
So it forms conformal layers, which gives the device mechanical stability, so that it doesn't rupture. As I mentioned, if you have anything on top of it which is very thick, there's every chance that you can delaminate it, you can destroy it. Polyphenol definitely helps in maintaining the conformal this thing. All right, I think that's all the answers I was looking for. Okay, Clark grid error. How does a Clark grid error validate performance?
we can know how well our sensor is working.
We can know how well our sensor is working. How?
So by knowing like it falls on the.
How do you plot a Clark grid error?
It was
How do you plot a Clark grid error?
concentration.
Concentration versus what? Concentration.
Blood, I guess.
Blood concentration? Yeah?
Sir, accuracy over time?
Pardon?
Accuracy over time?
Accuracy over time. Is it accuracy over time?
I barely remember.
That
the
was in
things.
Khalid's lecture, accuracy over time.
Oh,
What happens in Clark grid error? So if I asked you to make a Clark grid error, I'll draw it for you. Right, these are the different zones in there. What are you plotting here? Sorry, let's go one at a time. Please speak in the mic.
I think it's the blood reference value over here in the
Blood
y-axis.
reference. Yeah.
And the concentration that we are getting.
Concentration.
Blood reference.
Are you sure? This is your subdermal variable device output value versus CSI or YSI, which is venous blood value, right? So you are basically plotting the output of your sensors, because again, remind you, you are not measuring glucose, you are measuring the current values, and those values are processed using machine learning and AI tools and calibration steps into an output value, and you are then plotting that output value and against the blood reference value, and you're looking at the difference. If there's no difference, they will all fall along the straight line. If there is difference, they start moving away from either in this direction or in this direction, depending on positive or negative difference. Start moving out. Right? All right? That's good. Is Clark grid error clear to everybody? All right. Why is it narrow here and wide here? Why is it narrow in this region and wide in this region?
So the sensor works well for the low concentration.
Sorry?
It works well for low concentration.
Is that the reason why this is funnel shaped?
We have more margin of error in the wider concentration.
Repeat that answer in the mic, please.
We have more margin of error in the wider concentration, and then this.
Than this.
less.
Why? Yes.
Hyperglycemia.
Hypo versus hyper.
Hyper.
Right? So if somebody's glucose levels are high for a certain period of time, it will affect them, but over a longer period of time. But if somebody is in the low concentration region, there could be some serious consequences there. Okay, I think that probably takes me to the end. I hope I have given you a good flavor of subdermal variable devices and epidermal variable devices. If for some reason you found me showing more energy towards subdermal variable devices than epidermal, or if you see a bias there, it's for a simple reason. I've been working on subdermal variable devices for the last 15 years. But having said that, I still maintain the stand that these technologies are complementary, so I wouldn't rule out another technology. So if there's an opportunity and if I can access things through the sweat, I would go for that, especially for babies. If I can do something using sweat, I would go for that. All right. So I hope I've kind of given you the basic thought process behind building a subdermal devices, and I hope this is good enough information to motivate you and to encourage you to look into this area and actually find your own applications, or take this work further ahead and build on the strong foundations that you might have built through this workshop.
So yeah, just one last question from my side.
Yeah.
So definitely microneedles have a clear advantage over normal needles.
Yeah.
So why don't we see microneedle based products in the market right now?
That's because microneedles right now, as I said, they've been introduced in
It's long time,
1970s.
yeah.
There's the first microneedle product that's going to come into the market is going to be a ketamine patch,
It's going to come.
clinical application.
Okay.
If you ask me another patch that's available in the market, nicotine patches.
Those are microneedle patches.
Those are
always.
very small structures there, but those are not exactly microneedle patches.
Yeah.
But ketamine patches are microneedle based patches.
What about sensors? Why don't we see?
It's early days.
Early days.
None of the sensors have gone from TRL stage 4 to have reached TRL stage 4. There's actually a new company that's come up, if you want to look for that, BioLink. This is by a student from Joe Wang's group.
BioLink.
BioLink, BIOLINQ. That has been floated in the market. That's based on microneedles.
Right. Is it something to do with the manufacturing process, or no? It's just people.
It's
have
a mix
not
of
pushed
everything.
it?
It's a
Okay.
mix of all the regulatory hurdles. It's a mix of approvals from the MHRA and also the technologies as well.
Okay.
But there is definitely promise there, and I would strongly ask you to follow that company BioLink. They are coming up with these products.
Okay. Okay.
And actually that is good for us because it opens up the space for us to spin out a company, isn't it?
Yeah. Yeah. Just for the sake of discussion, just 2-3 minutes more. We need to extend the session.
How much do we need more?
Just 3-4 minutes.
Okay,
we
that's
have
fine.
3 more minutes.
Yeah.
And then we'll wrap up. So another question is, this applicator that you are designing, is it required for microneedles?
Absolutely, absolutely.
Can you design it in-house? Is this
Yes.
designed
So
in-house?
this one I've got the design as well. If you want it, I can. So the
Yeah,
applicator that
be
we've
good
used
to-
here, this one,
Yeah.
is all in-house. In fact, now what we're trying to do is, this is the, it's like a disk, a PCB disk. I did show you some previous studies there where we spoke about interference that we see, which comes from the base if they are metallized, fully metallized. So we've started using PCB disks, and we have our acupuncture needles soldered onto those disks, and then we have the wires and everything there, and on the back of it is going to be similar to what we have. As I said, we are using our digital twin to see what are the good things and take those ideas from this digital twin and transfer them on here. So next time on the applicator you will have something which, as I showed here from the that was in the animal study, sorry, the video. The applicator will then, so that was this applicator is for animal studies, but you can use similar applicator with lower forces and lower speeds in humans as well.
Okay.
But yeah, it's a very easy way of making applicators. You can get designs online on GitHub and all those things. You can look there. You can get designs for and even 3D. You've got these programs for 3D printing. So if you have a 3D printer, you can make your own applicator, and you can design the springs. You can adjust it yourself. You can do some studies yourself. You can order the springs, and you can have a spring-loaded applicator as and when required.
Okay. Thank you.
Yeah.
Like there is an applicator to insert the device or implant it. Do we need something to remove it? Like
I mean, this has to be in there for 14 days. Otherwise, I would have peeled it off and showed it to you. No, it's not for removing. I think your question is about, do you need another device to remove it? No. Even my mom could take it off when I implanted one in her. This is the device. This is the applicator. This is how it comes inbuilt.
and so the things that is inserted in cattle and all that.
In cattle, again, you don't need to. You normally have a adhesive, again, which you need to be very careful about the choice of adhesive. You can stick it into the animal. I think that's the problem we're going to have with animal with hair, especially horses and cows which have got thick hair.
Sir?
So is the force as well as the mechanism may change depending upon the type of the microneedle you are fabricating or making?
It will change on the type of the animal.
Type of the animal.
Yeah, because if you have horses, they have thin hair. The cows have got a much thicker fur. It depends on the animal. If it's a beef cow or if it's a milking cow. Normally, milking cows are more like as if you've waxed them. I mean, they still have hair, but it's very thin. Beef cow, they have got a very thick thing. So it will depend on the type of the animal you're working on.
Sir, I have a little question on the mechanism. So as we are applying the polyphenols a monolayer, so in the cells also ascorbic acids are present. We know that the polyphenols are also redox active. So now
Are polyphenols redox active?
yes sir, they are
100%?
redox active. Yes sir.
I thought they were insulating.
No sir, they are redox. I have personally tested them. So
But did you make sure that you've removed any phenol in there?
phenol.
So what happens is, have you done it when you test phenols?
Sir,
Did you start with polyphenol or did you start with or phenol?
No, polyphenols means like we are going with the catechol, pyrogallals, gallic acids, tannic acids.
Okay, that's your definition of polyphenols. When
Yeah.
I say polyphenols, what I meant is polyphenol as in the polyphenol that you obtain by the polymerization of the monomer phenol. You're talking about compounds that have got additional functional groups there.
Yes, yes.
I'm talking about phenol when the monomer phenol C6H5OH, when you polymerize that, the polyphenol you get out of that is insulating in nature.
Okay, so that's a polymer.
That's a polymer of the phenol.
Okay.
But if you're talking about, if you something polyaniline, for example,
Yeah.
you have a different functional group there.
Yes.
You may have some redox activity there.
Yeah.
Okay. Or you mentioned about catechols.
Yes.
They may have some functional groups, OH groups and NH2
Yes,
groups.
yes.
You will have some functionality there. But the phenol I'm talking about is phenol, which is basically C6H5OH, which when on polymerization gives you polyphenol.
Another question, sir. We know that as from the Marcus theory also, the electrons can move beyond with a certain distance. Okay, so they can also move for the nanometer levels. So is there any possibility that the reducing agents inside the cell, they are reducing the engineered glucose oxidase? Because as sir told yesterday that they are engineered and the FAD moiety is like naked outside. So that's why the redox potential is being very high, 0.65 volt. So is there any chance, because we know that this intracellular reducing agents like glutathione, NADH, like ascorbates, they can, they are very fast moving their electrons towards like anything.
Yeah.
So are they going to alter any changes, like they can produce the FAD superradicals or like that?
That's actually a very good question. So what happens with the microneedles is it sits in the interstitial fluid which is between the cells. That doesn't mean that they would not puncture the cells. They will puncture the cells, and anything inside the cells that is your concern will be released, but the concentrations are going to be very, very low. Right? What you need to appreciate here is, what is the concentration, what is the dynamic range for glucose, everybody? What concentrations are we measuring of glucose? Sorry? 0 to 40 what? Millimoles. Compare millimoles. What you're talking about atomolar concentration. Atomolar. Atomolar meaning very, very low. So when you have something which is very low there, below the baseline of your current.
I'm not asking about repetitive reactions. I'm asking that whether they are modified glucose oxidase.
Because that's what I'm trying to tell you. The concentration of those cellular products, intracellular products, is so that the concentration outside is very high. Like, you're forest fire, and you're taking a glass trying to do the fire off. You cannot, because the scale is different. Forest fire, the forest is and here's somebody who's just taking a tiny bit of that's what I'm. So your intracellular components that out of the cell, because by the microneedle, concentrations are so low that they will not here. That makes sense?
I think that's for today. If you have any, I don't think anybody has any more energy.
No, I'm sure. Let's let them have their
wrap
lunch.
it up. I think
They're sure they're all very hungry.
Thank you very much.
Really appreciate your patience. Really appreciate you being here. I mean, I really appreciate it. I mean, this is something which would have been virtually impossible in the UK, to get students to skip their lunchtime and attend lectures. Thank you so much, everybody.
Thank you. Thank you to you also.
It's thanks to you, wonderful people, that it motivates me to teach as well. Thank you.